Well, it's straight up 12 o'clock, and this is Elke Shaw Tulloch, and I would like to go ahead and kick off the meeting if everybody is ready to go. So we'll start with a few introductions and start going through some slides and bring you up to speed with our agenda. So right now, with a huge thank you to everybody for joining to the conversation. Again, my name is for the Division of Public Health in the Department. I am, if you've seen previous our committee members, I wanted to announce that I was previously listed in older, and we have, in the spirit of trying concerns about this advisory committee giving advice to the department, we've changed my role from a co-chair position to the executive secretary of the committee. Purpose later, but wanted to let you know that at the top of the Burgess.
Thank you. And thanks again, everybody, for system and serve an administrative role there as well. And on the board of the Idaho Medical Association, so I have a few different in advance of the next slide. As Elke said, today we're going to, one thing, many of you have probably served on advisory committees before, but one thing to remember, we are really a group to offer advice and to assist the state in making decisions. We are not making those decisions ourselves, but prioritization of who those vaccines would be delivered to, in what order, and how to implement the plan and communication delivery of the vaccine. The other issue to remember is vaccine or how it's vetted. That's being done in other areas. Our purpose is really to look at, once the vaccine has been determined to be safe and it's available, how do we distribute it? How do we get to right groups in the right sequence and make it equitable across the state? So just wanted to level set that before we get started. And I think Elke has the next slide.
Yeah, thank you, Dr. Burgess. I do want to encourage folks, if they feel comfortable before we get started, to have your cameras on, because it's nice to be able to see each other. We are assured that we have plenty of bandwidth to do so. So it's nice to be able to see all of your beautiful faces as we move forward and can have more of a dialogue with committee members. I want to go through our statement of purpose and the structure of the committee. What we try to do is cast a very broad net to make sure we had adequate representation, not only geographically, but different groups that may have higher risk factors for, contracting COVID, that are involved in healthcare and the potential delivery of the vaccine. As you can see here, tried to make it as broad as possible. Of course, we also want to make that, we had immunization organizations represented as well, because this is really about, how we prioritize some of these very limited vaccines coming into the state, and then prioritize those into subpopulations. And we'll get into a lot more of that in a minute. We also have invited some ex officio members to join us as well. They are representing governmental agencies that have a variety of roles in the pandemic response. Next slide. So for those committee members, and like I said, we have a broad spectrum and a large number of folks in this committee. Folks, if it's possible, to serve for the duration of this pandemic. We anticipate it. I'm going to do my fingers crossed. We anticipate less than a year. We're focusing on getting this vaccine into the state of Idaho and out the door to those who want the vaccine. It is a voluntary vaccine. The members that are on the committee, the members themselves have voting privileges. Like I mentioned, the ex officio members or their designees, whoever they're sending on their behalf, do not have voting privileges. Dr. Burgess says that she does have a vote, but as I mentioned at the top of the hour, as executive secretary and an employee of the Department of Health and Welfare, I do not have voting privileges. And we are using a process of voting by consensus. Next slide. We anticipate that this group will meet every other week. You saw in the invitation email to all of you that we're trying to at least schedule the next 2 meetings 2 weeks apart. We also wanted to, right at the very beginning of this, that as you are probably very well aware, this is a rapidly evolving situation with the vaccines. We're learning something new about it every single day. We learn, in a couple of days that something has quickly changed and we have to be more ready to receive vaccines into the state. So we want to have some flexibility with this group to make sure that we can go you on an as needed basis, to accommodate that rapidly evolving situation. But we're trying to keep it at a scheduled time and cadence, but just know that something could come. Feedback and decisions, we want to make sure that we're using a wide variety because this is such a large group. And we're trying to do these meetings virtually because we want to make sure that we have attendance across the state. And we've in a lot of our meetings that having this virtual platform really can allow us to have a lot more participation. And so we're going to wind up a variety of feedback mechanisms from everybody, whether that's a poll feature in WebEx events, we might potentially have to look at email voting, verbal counts. We'll have to work that out as we go. So we ask for some grace and flexibility. We're figuring this all out because it is a large group. And then as Dr. Burgess was talking about at the very beginning, that these final decisions that all are helping us make will help inform the decisions we have to make about some of those logistics about bringing the vaccine into the state and its distribution across the state. Next slide. As you may or may not have noticed, we are offering the opportunity for the public to also participate in this meeting in a listen-only mode, but we do want to make sure that we have opportunities that the public comments can be made into the process as well. So we will be accepting public comments in writing, and we have created a new designated email for comments to come in, but we also want to make sure that the committee members have access to those. So if comments are received at least 24 hours before the start time of the meeting, then we'll be able to share those comments with this advisory committee. So throughout the course of this, of course, we'll be checking the chat feature for committee members. That chat feature is for committee members. I think that Monica will go over this in a minute. But we do want everyone to know that this is the email box that is available. And perhaps at some point along the way, we can also bring this email up. But I'm talking long enough, hopefully, that people can write this email down. COVID-19 vaccine public comment at dhw.idaho.gov. So that is the public comment email. So next slide, and I think I'm turning it over to Dr. Burgess.
I was saying we're going to learn a little bit more about how we're going to be able to vote on this platform and some of the different rules on the electronics. But toward the end, we're going to be asking for some input. So I wanted to give you a preview of those questions that you can be ready to vote on later on. So the first question will be approving whether or not you approve the goals of the vaccination plan. And then next one will be whether or not you approve of the principles of the vaccination plan. And then finally discussing and considering the sub-priority groups. So we're going to have our consultant to walk us through the technology and kind of get us off to our next steps. So I think Monica next.
Excellent. Thank you. Thank you, Elke and Dr. Burgess. Good afternoon. I'm Monica Rabosi, and I am the independent facilitator for the advisory committee. I am independent in that I am not employed by the Department of Health and Welfare or any other agencies, and I'm here to help flow of the meeting. The first thing we'd like to do is start off with introductions, but because we have such a large group and a short meeting, we will do it roll call style. And I'd like to make sure that you notice that we sent out bios for the advisory committee members in advance, So please go ahead and refer to those if you'd like more information. I'm going to do this quite quickly. And if I miss anyone, please make sure you let us know when I get to the end of the list. Also, as the slide says, let us know if you're attending as a designee for an advisory committee member. So here we go. And I apologize in advance if I mispronounce those names. So once I call your name, if you could please be ready to unmute and say present, that would be fantastic. We'll do this pretty quickly. All right, in alphabetical order, if that helps. Daryl Anderson, Chair, Idaho Rebounds Committee.
Present.
Thank you. Paul Arnell, President, Cascadia Healthcare.
Present.
Thank you. Dr. Richard Augustus, Chief Medical Officer, West Bend Medical Center. Okay. Dr. Tim Ballard, Chief Medical Officer, East Idaho Regional Medical Center. Matt Bell, Vice President, Idaho Regional Director, Pacific Source.
Yes, I'm here.
Thank you. Sam Bird, Executive Director, Centro de Comunidad y Justicia. Sam? And a quick note, and I'll review this more later, but I need to unmute myself on the right side of the screen where the panel with the listing of names is, in case you're for your mute and unmute button. All right, Dr. Karen Cal, Chief Physician Executive, Kootenai Health.
Present.
Thank you. Rebecca Coyle, Executive Director at the American Immunization Registry Association.
Present.
Dr. Ab Davids, Fellowship Director of Family Medicine Residency of Idaho.
Present.
Rachel Edwards, Secretary, Nez Perce Tribal Executive Committee.
Present.
Karen Echeverria, Executive Director, Idaho School Boards Association.
Present.
Thank you. Dr. Aaron Gardner, Chief Medical Officer, Just for Kids Urgent Care.
Present.
Amy Gamet, PhD, Public Health District Representative.
Present.
Thank you. Rob Geddes, Director, Pharmacy, Legislative and Regulatory Affairs for Albertsons.
Present.
Dr. Dan Snell, Chief Medical Officer, Portneuf Medical Center. Randall Hudson. Thank you. Randall Hudspeth.
Sorry about that.
No problem. This is quick. Randall Hudspeth, Executive Director, Idaho Center of Nursing.
Present.
Dr. Jeff Keller, Chief Medical Officer, Centurion.
Present.
Yvonne Ketchum Ward, CEO, Idaho Primary Care Association.
Present.
Mel Leviton, Executive Director, State Independent Living Council. Dr. David McClellan III, Medical Director of Quality and Safety, St. Luke's Wood River, former founding chair of Surgery ICOM, Priester for ISU PA program.
Present.
Thank you. Dr. Kelly Graff, Chief Medical Officer, Clearwater Valley Hospital.
Present.
Salome Mwangi.
Present.
Oh, okay. Thank you. Salome Mwangi, Social Integration Refugee Bureau Coordinator, Idaho Office of Refugees.
Present.
Thank you. Christine Hoff, Vice President and Chief Legal Officer, St. Luke's Health System.
Present.
Dr. Dave Peterman, CEO, Primary Health Medical Group.
Present.
Catherine Quinn, City Officer, St. Alphonse Health System. Catherine?
Present.
Thank you. Dr. Daniel Reed, Director of Family Practice, Primary Health Medical Group.
Present.
Thank you. Dr. Curtis Sandy, Medical and EMS Director, Portneuf Medical Center.
Present.
Karen Sharpnack, Executive Director, Idaho Immunization Coalition.
Present.
Linda Swanstrom, Executive Director, Idaho State Dental Association.
Present.
Nathan Thompson, Physician Assistant, Idaho Academy of Physicians Assistants.
Present.
Thank you. Dr. Julio Vincente, Pastor, St. Edward the Confessor Parish. Dr. Elizabeth Wakeman, Associate Professor, College, Idaho.
Present.
Thank you. Brenda Ward, Practice Manager, Minidoka Medical Center.
Present.
Brian Whitlock, President and CEO, Idaho Hospital Association.
Present.
Lauren Wilson, Association of Professionals in Infection Control and Hospital Epidemiology. Lauren? Okay. Lupe Whistle, Director, AARP Idaho.
Present.
Dr. Casey White, Sawtooth Epidemiology and Infectious Diseases.
Present.
Thank you. Those were our advisory committee members. At the very end, I'll make one more call for anyone we might have missed. So hang in there if we weren't able to jump in time. Next, I'm going to call the ex officio members, starting with Russ Barron, Executive Director, Idaho Board of Nursing.
Present.
Dean Cameron, Director, Idaho Department of Insurance. Chris Carter, Career Epidemiology Field Officer, CDC.
Present.
Sorry, this is Lola going back to Dean Cameron, Idaho Department of Insurance. Director
Yes.
Cameron is still trying to log on. I'm his assistant. I'm in for a minute.
Very good, thank you.
Thanks.
Nick Chopsky, Executive Director, Idaho Board of Pharmacy.
Morning, present.
Here you are. Alicia Esty, Chief of Staff and Vice President for Compliance, Legal, Public Health, and Audit, Boise State University.
Present.
Margie Gonzalez, Executive Director, Idaho Commission on Hispanic Affairs. Dr. Magni Hamso, Medical Director for the Division of Medicaid, Idaho Department of Health and Welfare.
Present.
Dr. Steve Malik, Chair, Idaho Board of Medicine.
Present.
Tim McMurtney, Deputy Operations, Department of Education. Danielle Perry, Bureau Chief, Division of Behavioral Health, Idaho Department of Health and Welfare.
Present.
Tamara Prizzett, Administrator, Division of Licensing and Certification, Idaho Department of Health and Welfare.
Present.
Brad Rich, Director, Idaho Office of Emergency Management.
Present.
Judy Taylor, Administrator, Idaho Commission on Aging.
Present.
Josh Tewalt, Director, Idaho Department of Corrections. Okay, let me pause for a minute then. Is there anyone who wasn't able to let us know that they're here? If you could quickly just introduce yourself and your agency, just as we did in roll call.
Lisa Sherrick, Idaho State Department of Education.
Thank you, Lisa.
Officio.
Thank you. Anyone else? Excellent. So before we wrap up roll call, I'd like to also point out that we have a few staff members from the Department of Health and Welfare, folks who are helping us behind the scenes navigate the meeting today. And those are Dr. Chris Hahn, Dr. Kathy Turner. They will be helping with our chat function. We'll talk more about in a minute to help manage that with a large group, with Angela Wickham, Misty Daniels, and Bill Evans from the Department of Health and Welfare, and Natalie Brown from the CDC Foundation.
Monica?
Yes.
Excuse me. Hi, everyone. This is Angela Wickham. I am working with Father Julio Vincente to get him on. We're having some technical difficulties, but hopefully he can.
Thank you for letting us know. Thank you for doing that. All right, so I think that brings us to the end of roll call. And next, I'd like to give us an overview of the meeting and the ground rules and some housekeeping to get started. So if we could have the next slide, please. So in advance of the meeting, I don't expect anyone to be able to read this. Just for visual, this was the agenda that was sent out. And I'm going to now highlight a couple areas on a little closer so that you can see. And before I start that, I just wanted to mention that this has changed only slightly from what you received in advance. Content-wise is exactly the same, just reorganize things a little bit to integrate the discussion in some of our presentations, which I'll talk about in a minute. As you can see, we are down at the second item right now, roll call and meeting overview. And then what we really want to do today, as was mentioned earlier, is to provide a common foundation of information for the advisory committee. So we will have an introduction context for the advisory committee with presentations. First one with Sarah leads an overview of COVID-19 vaccine planning status. And then Dr. Carolyn Bridges will give us a background on vaccine prioritization frameworks and considerations of prioritizing the vaccine among healthcare personnel in Idaho. So again, we'll have a presentation there, and we'll have some specific times for you to provide input. As we've been mentioning, large group and short meetings. So if we don't get to all of your comments today, don't worry. There will be specific opportunities for everybody to input between this meeting and our next meeting. The next item on the agenda, and this might be as time allows, we'll see how it goes, but if we can, we'll discussion today about how we inform others of the advisory committee work, advisory committee's work. What do committee members need to resonate or communicate messages with people in their spheres of influence? So you're out there, you're hearing the questions people have, and what we really want to do here is have accurate and consistent information that is going out into the community with the folks in your circles. So that's our intention. To get there today, that'd be great, but please be thinking about that either way. And of course, we'll wrap up. We'll talk about the action items between today and our next meeting, talk about what's happening for our next meeting, and then we'll adjourn. That's our for today. Now, I'm going to go on to ground rules, which are at the bottom of that agenda sheet if you have the hard copy or if you have it up on a screen yourself where you can read it. And I just wanted to mention, if you have any questions about the agenda, the ground rules, or the housekeeping, please go ahead and put those in chat, and we'll pause at the end of our meeting and see if anyone has any questions. So let's talk about our ground rules for the advisory committee itself. And these are pretty general ground rules, but I think it's always useful to have a good reminder of them. So number one, of course, is to respect all aspects of diversity in the group. Knowledge, background, expertise, just about every aspect that you can think about. Because, of course, that is our goal in terms of making good decisions to get as many perspectives to hear from everyone. So that leads us to number two. Please be mindful of allowing space and authentic consideration of all stakeholder perspectives. This might mean that we have to be a little bit concise with our feedback during the meeting, especially if we're speaking. But just a reminder to be mindful of that because we need to hear from everybody. Be open to new ideas and approaches. Participate actively. We really want you to be able to share all of your best wisdom thoughts with the group. Be forward focused, meaning we're going to start from where we are today and move forward, not backward. Stay focused on the committee goal and corresponding topic at hand. I really appreciated we spent some time in the beginning forcing what our goal is for this particular committee. And of course, we'll want to stick to the topics very closely and try not to get too down in the weeds, which is easy to do sometimes. So help me with that, committee member, please. And we will utilize the parking lot, number 7, for important topics to be addressed another time. We don't want to dismiss something it's not in alignment with the agenda item, but we want to capture that. But we'll keep a list and make sure that we can bring that back at a later time. And then number 8 is also very important for a group like this. Everyone is on equal ground. As we've been saying up until now in the ground rules, everyone's perspective is very, very important. We want to be able to hear from everybody and all those stakeholder perspectives in light of the goal of this particular committee. So to help with that, one thing that helps with these kind of groups is that we'll be on a first name basis. So I invite you to all interact in that way with one another today in our meetings. Now we have a couple of remote meeting specific ground rules. Of course, please mute your microphone when you are not speaking. Inevitably, we'll get some background noise. Please use the raised hand feature, which I'll show you in just a minute to prevent multiple participants speaking at once. And to interact, use the chat to ask questions, polling as requested. And some of those features today, some of them we'll use in future meetings. So with that, if we could do a quick housekeeping, the next slide. There we go. So yesterday, I believe, you received WebEx events tip sheets, just some extra information as to how to navigate this particular video meeting platform. So if you want to keep that handy, there's some good information there. I just wanted to remind you that you had that. And then I just want to quickly review the advisory committee member participation functions for this meeting. We could have the next slide. Mute and unmute. So I mentioned this quickly earlier, but go over it one more time. If you look on the right-hand panel, I believe your list of participants, so the written list of participants will appear on the right-hand panel. That seems to be the best place to unmute. I've tried to do it on the thumbnail picture, and it has worked there. So you can quickly respond. I think you will have practice in the roll calls. That's good. And as it was mentioned earlier, if you can keep your video on so that we can all see one another and become better acquainted in that way, it would be great. Hands up function can be found. Now I'm trying to find where my hands up is. I might have to have someone jump in because I saw this earlier. Oh, over here in the, okay. So I'm seeing it. So if you go over to the right side where we notice that we have the mute button, to the left of that is the video button. So this is the left of your name. Hands up should be to the left of the video camera. Can everyone, if I'm mistaken, if anyone wants to jump in on that, I'm just not seeing the hand up. We practice. Oh, I see. No, I am mistaken. I apologize. It's down at the bottom of the list of names. There it is. All right. So if you look down at the bottom of the list of names, but above the chat, there's a bar and there is a hand on the left. That's how you click hands up if you'd like to provide verbal commentary during the meeting. And to the chat function is down below, as you can see, where you can type in your chat messages to the group. Chris Hahn and Kathy Turner will be monitoring our chat. And I'm really, really grateful to have them doing that so that they can kind of look at what comments we're getting. If they're common comments, they can kind of integrate them and make sure that they're heard by the committee to the best of our ability with the time we have today. And we also have a couple of folks checking for hands up. So this is going to be a team effort. Back to the hands up square, I'd like to just go to the right of that. There seems to be a bit of a megaphone button there. That is for quick feedback. If you click on that, you'll see that there are some very quick responses, yes, no, and so forth. And that is only for quick feedback during the meeting. So if we're having any technical difficulties, we could reach out. You can give feedback that way. Yes, no, we can hear, we can't hear. Also, if we have a specific content-related question for you, that might be one way we gather feedback as well. So that's the quick feedback or megaphone button. Now, yes?
Excuse me, this is Angela Wickham again. I just want to let you know that Father Julio Vincente is now able to join us, and welcome, Father Julio. Sorry for the inconvenience.
Excellent. Thank you. Thank you for that, Angela. Welcome. All right. I'm going to pause quickly here and just check in and see if there are any questions or comments on the meeting overview, our agenda, our ground rules, or anything else before we get moving on our presentations.
Monica, this is Angela again. I see a hand raised from Karen Sharpneck. Did you have a question, Karen? A comment?
I'm going to go ahead and
I just haven't undone it. Sorry.
No problem. You're practicing to make sure it's working.
Yeah.
Excellent. Thank you, Karen. I do see something in the chat. Normally, I wouldn't be the one jumping in here, but this, what we hear is that up in McCall, we're on audio, given limited bandwidth here. Depending on the equipment you're on, it will determine where your buttons are. Yes. So your buttons may not be on the right-hand side panel as I pointed them out to you, but I hope that you can all navigate around and find your mute, unmute, and the hands up, which will hopefully be all near the participant, the written participant list, where you see just the names and then the chat function. If you're having trouble with that, let us know, and we have folks on board who can help you navigate that. All right. With that, I'd like to move forward then to our presentations, the purpose of which is to provide introduction and context for the advisory committee. Very important that we all start with a common foundation of knowledge in our work together. We will have a presentation, as I mentioned earlier, as an overview of the COVID-19 vaccine planning status, and a background on COVID-19 vaccine prioritization frameworks and considerations for sub-prioritizing vaccine among healthcare personnel in Idaho. This is where we'll have presentation and discussion. And before we get started, I would like to ask Elke to introduce our presenters.
Thank you, Monica. I also wanted to point out that I do see that Sam Bird has joined the call. So you're welcome to Sam as well.
Welcome.
Yes, our first presenter is Sarah Leeds, and Sarah runs the Department of Mold Bearers Immunization Program. And you can see that the title of her presentation that she's going to be giving. So I will welcome Sarah in just 1 minute. And I also want to welcome Dr. Carolyn Bridges. And Dr. Bridges is a board-certified internal medicine physician. She has worked on influenza and adult immunizations for over 24 years. Most of that time was at the Centers for Disease Control and Prevention, where her roles included the Associate Director of Science for Influenza and Associate Director of Adult Immunizations, where she was involved in influenza pandemic planning. After she retired from CDC, she came back to Idaho and started a consulting company. She's currently a member of the governor's coronavirus work group, and she's also supporting the department in a part-time capacity for us to help us advance many issues related to the pandemic response, and most recently this work with vaccines. So we welcome both of them, and Sarah, we'll turn it over to you.
Thank you, Elke. So I would like to start with just an overview of our plan and to date, of our planning process to date. So the immunization program began planning for COVID vaccine in the spring of 2020, and we were having calls with the CDC and participating with all jurisdictions around the country in learning information about the potential vaccines, what we needed to do with our immunization information system, and we decided to convene a COVID-19 vaccine task force, and that first meeting was on June 29th. And they were provided with some updates. The group was much smaller than this one, but we tried to get a little bit of a broad representation to the extent possible with limited information from CDC and about the vaccine planning. And so to try to be as efficient as possible with folks' time, the task force was a little bit smaller than this group. In June, we also had a great opportunity to focus on adult immunization in a much bigger capacity than the immunization program has ever had, with some supplemental funding and some additional adult doses that are arriving late season for influenza, which gave us the opportunity at the immunization program to have new funded partners with our community health centers and federally qualified health centers. And the goal of all of that was to increase influenza coverage among adults, with a particular focus on adults who have high-risk conditions that make them more susceptible to severe outcomes while COVID-19 or SARS-CoV-2 virus, the virus that causes COVID-19 and influenza are circulating in the community simultaneously through these winter months. So we have about 47,500 extra doses of influenza for adults that are available to our providers, and that we booked in June as an order with CDC. On September 16th, the CDC issued their playbook, which was the plan, which was the framework for the plan that we had 30 days to put that together, 15 sections across the spectrum of what we will need to do to roll out this COVID-19 vaccine program. CDC and we acknowledge that this plan is a living document. And so even though that was submitted on October 16th, CDC insisted that that plan be as we learn more information about the vaccines through the FDA, and as we learn more information about how we're going to roll this out, and also get feedback from you all and other stakeholders. So that plan is most definitely a living document that will be updated. And so that brings us to today, where we have convened a vaccine advisory committee with this first meeting. So next slide, please. So while we are doing a lot more than just this list is some of the current prioritized work with COVID vaccine rollout. So we are now in the process, the immunization program is recruiting and enrolling, about to recruit and enroll providers for phase 1 in anticipation of rollout of the arrival of doses with the first vaccine that will get approved at some point in the future. We are also conducting a vaccine capacity assessment with providers, and that survey will be distributed very soon so that we can have, as we plan for vaccine, we can have an idea of what the vaccine providers around the state, what their capacity is to vaccinate in large amounts over a short period of time. We are also working, and we have worked and are continuing to work on priority population subgroup identification, and Dr. Bridges will be talking a lot more about that after I'm finished. We're focused very heavily right now also on ancillary supplies and assessing what we need. There's some vaccines that we anticipate will be approved by the FDA that have some very complex storage and handling requirements, and so we're working with our partners to make sure everyone has the capacity to work with that vaccine. And we're also ensuring that our IRIS, our immunization information system, is ready to collect that data for when we begin administering vaccine. Next slide, please. So we're going to, as I mentioned before, we're going to be in recruiting and enrolling providers on a phased basis. So there's going to be 3 phases of enrollment that will match the vaccine, what we anticipate will be the vaccine distribution. And phase 1 will be, we're trying to roll that out as we enroll providers who will be those first vaccinators, and vaccinating those populations that are identified by you all as the first ones to get the vaccine. And we anticipate that CDC will say healthcare providers. And so we're enrolling vaccine providers who have the capacity to vaccinate healthcare providers. And we're using various forms of data to kind of assess that and identify the most logical vaccine providers. Next slide, please. So this is what we anticipate the phased enrollment to look like. Public health districts, hospitals, our community health centers and federally qualified health centers, our tribal, our partners at tribal health clinics, pharmacies who will be able to vaccinate long-term care residents, and large healthcare systems. And then as we move into, this is for when vaccine, we assume, will be in very small supply. And then when we move into phase 2, when vaccine is more available in higher numbers, when doses are available in higher numbers and they get distributed to states in larger quantities, we will be working with more providers, pharmacies who will vaccinate the general public, correctional facilities, urgent cares, and moving forward. And then phase 3 is when there's not very much concern about the supply of vaccine. Next slide, please. So as I said, we're starting the enrollment process. We're going to be distributing the information next week to providers and holding a meeting soon thereafter to answer questions and get that process rolling. Next slide, please. So I also want to cover two slides. This slide and the next slide will cover the distribution of the actual vaccine, because it's different than than H1N1, as many of you might remember. We will be distributing vaccine, with the exception of that ultra cold vaccine from Pfizer, in the normal routes that we distribute pediatric vaccine and routine vaccinations that are in the routine schedule. So it comes from the manufacturer, it goes to the McKesson distribution center, and then it is shipped, allocated through the immunization program to the vaccine provider. So that's really no different than what we do now with pediatric vaccine and the routine immunizations. Next slide. So this is the distribution flow for the ultra cold vaccine. Because it has some very complex storage and handling requirements, it will not go to the McKesson distribution center. It will go right to the vaccine provider as it's allocated through the immunization program. Next slide, please. So I just want to make a clarification of pharmacies in phase 1 versus phase 2. CDC has entered into a contract with Walgreens and CVS pharmacies nationwide to provide COVID vaccine to long-term care residents, skilled nursing facility residents, and assisted living facilities in phase 1. And then pharmacies will be able to provide vaccine to the general public in phase 2. And right now, long-term care facilities are in a process of selecting whether they want to go through their pharmacy contractor or work with the state immunization program to get vaccine through the state distribution process. Next slide, please. So I just want to talk about data readiness and let you know that we are working with our immunization registry and also another mechanism called PrepMod to ensure redundancy. So what we know, redundancy in data collection, because what we know is that many of the COVID-19 vaccines will require 2 doses with either 21 or 28 days spaced in between them. And right now, the manufacturers are saying that the doses, the brands of vaccine will not be interchangeable. So if, for example, you get the Pfizer vaccine for dose 1, you have to get the Pfizer vaccine for phase 2. And so it's going to be really critical that we be able to remind people that they're ready, it's time for their second dose, and also be able to know which vaccine they got in that dose 1. So we do know that there will be vaccination cards that a vaccine recipient will get when they get their first and second dose, that it will confirm that. But, we know that pieces of paper get lost, and it will be critical to capture in the electronic health record that which dose, which brand people got. So we are working to ensure redundancy in that data collection with IRIS, and also with a software tool called PrepMod that the state has purchased. That it's an end-to-end pandemic management tool that has a lot of really useful features for vaccine providers and also the public. Providers will be able to schedule vaccine clinics and ensure efficiency in setting up, and public will be able to use it to set appointments. And so that will be part of our provider enrollment or training when we enroll providers. And it's also going to be critical to track to at least know in case there's an adverse event. So we're ensuring that all of our states' capacity is there for data readiness. And as we just to wrap up, next slide, please. As we move forward and this group convenes, we'll share what we know from CDC. We're going to gather more input, and as I said at the very beginning, the plan will continue to evolve. And we're very grateful to everyone who has provided input so far, and we look forward to getting additional input. So thank you. And at this point, I think we might have a couple minutes for questions, and then I'll hand it over to Carolyn. Do we have questions in the chat box?
Sarah, this is Angela.
Nothing in the chat box right now.
Okay, sorry. I do see one hand still up from Karen Sharpnack. I don't know if that's a leftover, or Karen, do you have a question or comment? If not, I see a hand raised from Daniel Snell.
Yeah, thank you. Is the prep mod data, is that going to mend well? Or, I mean, are those interfaces set up for the hospitals and the places that are going to be entering that data? Do they have that? Have they started that?
We're working on that right now. Yeah. So the intent is not for providers to have another point of data entry, but that there'll be efficient data exchange.
Sarah, I also see a question or hand raised from Daryl Anderson.
Hi, Sarah. Daryl Anderson here. First, and I'm a non-medical person, so my questions may be basic to some of you on this call. But my question is on the phase 1s, 2, and 3, and their priorities, the entities included in each of those phases. Is that something that was sort of directed by CDC, or is that something that your previous group came up with in categorizing those 3 phases? And so I would just, it's more a curiosity question, is to understand how those 3 phases came up.
Yeah, so, and that's a great question. We came up with those as a proposed way to enroll providers, both internally to the immunization program. We've talked with our public health districts and tribes about it. We have weekly calls with them, and also looking at data, and also the capacity of providers to administer vaccine in really efficiently in a short amount of time. So those were some of the ways we identified.
So just to clarify then, in phase 2, when it goes to, if I read this correctly, is that when it sort of starts getting more to the general population, or is phase 1 still part of that a general population access?
They overlap a little bit. That's a great question. And Carolyn will be able to get into this a little bit more when she presents the prioritized population. Prioritized populations are also a variable that play into this, and also the amount of vaccine that we're getting, which we don't know how much that will be when vaccines are first approved.
Sarah, we have a hand raised from Director Dean Cameron.
Hi, Sarah.
Hi.
And Daryl started to ask some of the questions I had. And so I'm just trying to understand. So when it lists, for example, correctional facilities in phase 2, is that speaking of the providers who are working at correctional facilities, or are we talking about the population at correctional facilities?
It could be both, and that's one of the parts of the plan that we don't exactly know the answer to yet. And it also depends on the facility. So there's so many variables in the plan that we need more information on. So for example, the Bureau of Prisons, we are under the understanding from CDC that they will be vaccinating employees, and I believe their inmates as well. But we also need to account for local jails, and so there's some nuances in there that we don't have the answers to yet.
Okay, and I guess I'm trying to get my foundation as to to our role, but let me ask this question. Has there been any consideration towards educational facilities and teachers and where they would fit in the phase? I mean, it seems to me if we're wanting kids to go back to school, that they should be towards the front. Obviously, the providers are first, but then some of the first ones after that ought to be the teachers.
Yeah, so that is going to be addressed. You guys will talk about that a lot more in the discussion with Dr. Bridges, because she's been leading our effort in creating this sub-prioritization plan. And I just want to emphasize that the phases that I showed in that one in the slide that's on the screen right now are in vaccine provider enrollment.
Okay.
Yeah, but you're right. So teachers are I guess I would say an essential worker category that Idaho needs to identify where they will be in our plan. So more to come on that.
Thank you.
You're welcome.
Sarah, we have a raised hand from Rob Geddes.
Thanks, Sarah, for the concise presentation there. Just a quick question from pharmacy standpoint. Our understanding of the CVS and Walgreens agreements is that they're going to be required to service the long-term care facilities that are within 75 miles of their store locations. Understanding the rural nature of Idaho, we do have a large population of both independent and then other more local chain pharmacies. Do you expect to be able to call upon those individual pharmacies to help immunize those long-term care facilities that fall outside of that radius?
We are still working on that. Yes, we need to make sure that, because there, like for example, there are very few CVS pharmacies in Idaho, as you know, and so we're looking at that and where we can get those folks vaccinated and who we can enroll to be their providers.
Okay, we certainly, I would just say that we'll stand ready to help out in those pockets where there's not somebody already selected and able to help out. So just to think of the other pharmacy participants that would be able to stand up and help in that avenue.
And I think we're going to have a lot of those in Idaho. So I appreciate that. Thank you.
Sarah, we have a Lupe Whistle with her hand raised, and I would like to remind members, if your comment or question has been answered, could you please unraise your hand? Thank you.
And Sarah, thank you. This is Lupe, and I was looking at phase one, and one of the questions I was going to ask was asked by Daryl and by Director Cameron in regards to whether, for example, long-term care facilities, whether that included the staff and the residents. But in addition to that, as you list them, are they listed as priority or, because I'm looking at phase one, not knowing what the availability is going to be, et cetera, so are they listed in priority level here?
Do you mean on the screen, like yes. Public health districts first? Right. I would say they are not listed in priority. It's just a list. Yeah, that's a great question.
Thank you.
What was your, did you have another question?
No. I think that if I understand, when you look at as long-term care facilities, that covers staff and residents, correct?
Well, the pharmacies will be vaccinated. My understanding is the pharmacies will be vaccinating the residents, and the staff will. We assume CDC is going to be identifying healthcare providers as that top tier, and that they would be vaccinated at a facility where healthcare providers would get vaccine. Does that make sense? That's my understanding of the program.
Okay, so are the residents in phase one or phase two? I guess that'll be the simplest.
I'm sorry, are the residents
of long-term care facilities, are they phase one or phase two?
To get the vaccine?
Yes.
I think so. This is going to be like of a not wiggly, but it's a. I think it's also going to depend on whether the long-term care facility contracts with Walgreens and CVS versus getting distribution through the state. Because I don't know how the priority will go there. That's kind of an answer, a non-answer answer. But does that make sense to you? What I'm saying?
Well, I'm sure we'll discuss this further. Of course, when I look at long-term care facilities, and residents, I mean, they're the most vulnerable. And
yes,
and that is why the concern, yes.
Yeah. So as we go through Dr. Bridges' presentation, we'll be talking about those prioritized populations within healthcare providers, or you all will be talking about that and making some recommendations. And what we don't know as an immunization program right now is whether those large chain pharmacies will get distribution before state jurisdictions or at the same time. That's what I'm trying to get at, and that I don't know the answer to that, but that could play into who would get the vaccine first, if that makes sense. But we do know that long-term care residents are very high risk and are high in the priority.
Sarah?
Yeah.
Hey, this is Chris Hahn. We have a question from Steve Malik about, is there a plan for distribution of the ultra cold vaccine to rural areas, such as a medical van system or something like that?
It's a great question that we are learning more information multiple times a week from CDC and yes, mostly CDC, and also from Pfizer. We are working on that plan. We do know that that has a lot of complex storage and handling requirements, and the thing that we had been hearing prior to, I'd say even just yesterday, was that we were being strongly discouraged to not redistribute the boxes, and so there's a lot of vaccine doses in one shipment that will come, and so now yesterday it sort of felt like on a call that the door was opened that we would be perhaps redistributing. So the plan is evolving, but yes, we are working through options for mobile clinics, whatever it's going to take to get that vaccine to all our rural areas as well.
Thank you, Sarah. I'm sure we have more questions from the group, but we are running a little limited on time. So I think the best thing to do right now, if you have further questions, please keep them coming in the chat if you would, and we'll find a way to get those answered, but they may also be answered in our next presentation.
Monica, I'm
yes.
sorry to interrupt. This is Angela. I think it might be helpful if Dr. Burgess could articulate her chat to everyone. I think it might help clear up a couple comments. If you could, Dr. Burgess, thank you.
Yeah. Actually, Dr. Turner was the one that brought this up. What you're looking at on the slide right now is the distribution of the vaccine to people that will be giving the vaccine. So providers of the vaccine, not people that will be receiving it. That's actually what Dr. Bridges is about to talk about. So these priority groups will be those that will be actually administering the vaccine.
Great, thank you so much. And so hopefully that clarifies some of your questions. And if you have others, we don't want to discourage your questions. We just want to make sure that we can cover all our good foundational information today. So with that, if we can, I'd like to shift to our second presentation with Dr. Carolyn Bridges with regard to more information on the prioritization frameworks and so forth. Dr. Bridges?
Yes, thank you so much, Monica. Next slide, please. So I will cover today, it's my screen here, some of the planning assumptions, just to reiterate what some of the things that Sarah mentioned. I'm going to talk about some of the vaccine prioritization frameworks that have been published or are in development. I will discuss where we are with the draft Idaho Healthcare Personnel Vaccine sub-prioritization. And then we'll have a discussion about the goals and principles for Idaho COVID-19 vaccine program and discussion of the healthcare personnel sub-prioritization. Next slide. So as Sarah mentioned, we anticipate that the vaccine supply for 2020 will be limited. We don't know how many doses will be available when and what that speed of manufacturing is likely to be. The prioritization of vaccines, so in larger groups, will be recommended by the Centers for Disease Control as well as likely others within the U.S. government. So we are waiting on some of those final decisions. But it is likely that some sub-prioritization within those prioritized groups is likely to be needed, and the individual states have a say in that sub-prioritization. And as Sarah mentioned, most of these vaccines are 2-dose vaccines. You'll need the same brand for dose 1 as you get for dose 2. Next slide. I also want to just reiterate what the safety issues are. As Sarah mentioned, that vaccine tracking is going to be incredibly important. So we know how many people got each different type of vaccine and from each different lot. And that helps us with understanding any safety issues that might be identified. But there are multiple layers of safety and effectiveness evaluation for any new vaccine, including these COVID vaccines. So the study protocols that are in place right now, where they're doing recruitment of volunteers for studies, they are first reviewed by the Food and Drug Administration and then ethics committees at the various institutions that are conducting those studies. And they set rules in advance about when these studies would potentially be halted and reevaluated. Each of these studies also has a data safety monitoring board, which is a separate group. They include statisticians and other experts, and they're able to review unblinded data during the study if necessary. So independent from the researchers or investigators, they can see which people got vaccine and which got placebo and look at potential safety issues while the study is being conducted. In addition, vaccine study results are reviewed by the Food and Drug Administration. The FDA also inspects vaccine production plants. And then FDA also has an outside advisory group called the Vaccines and Related Biologic Products Advisory Committee, and they look at safety and effectiveness. In addition, you have another layer, which is the Centers for Disease Control and CDC's Advisory Committee on Immunization Practices, which will also evaluate effectiveness, safety, and recommended uses. Next slide. So we have a number of vaccines in different stages of development. Phase 1 clinical trials, those are very small studies generally, 20 to 100 or so volunteers, and they're looking again at initial safety and immune response. When phase 1 trials go well, then they move on to phase 2 studies. Those are somewhat larger. You may have several hundred volunteers. Again, safety is a key feature that they're looking for, as well as immune response. And then phase 3 are the much larger studies, and in those phase 3 studies, you will have generally tens of thousands of volunteers. And again, they're looking at safety, immune response, and then clinical effectiveness. How well is the vaccine actually preventing disease? Next slide. So this table shows some of the vaccines, not all of them in development, but more than 100. But these are vaccines more likely to be available for the U.S. market. There are likely others. I've highlighted the 2 with the red box that are furthest along in their clinical trials. So one of those vaccines is Moderna. The other one vaccine is made by BioNTech and Pfizer. They're both mRNA vaccines, messenger RNA vaccines. They're both 2-dose vaccines. One is given days 0 and 28, the other at day 0 and then 21 or more days later. The challenge with the Pfizer vaccine, that Sarah mentioned, is it is shipped on dry ice. And then with the Moderna vaccine, it's shipped at -20 degrees. Those are both going to be challenges. The Pfizer vaccine in particular is shipped in large quantities of almost 1,000 doses per shipment. The Moderna vaccine can be shipped in doses of 100 doses. So we're awaiting the end of their phase 3 studies and evaluation of the safety and effectiveness. We have other vaccines in development in phase 3 and phase 1, and 2 vaccines that are both adenovirus-based vaccines. That's the Janssen vaccines and the AstraZeneca Oxford University vaccines. Both of those trials have been paused in the U.S. while they evaluate an adverse event, although those trials, vaccine trials, are going on currently in other countries. Next slide. So the Centers for Disease Control and Prevention and their advisory committee, the ACIP, had discussions on COVID-19 vaccine prioritization during their September 22nd public meeting. I want you to be aware that they are having another meeting that starts next week. It's a 3-day meeting where they will further be discussing COVID-19 vaccines and vaccine prioritization. So in their meeting, the goals that were discussed for the national vaccine program include minimizing death and serious illness, preserving functioning of society, reducing the disproportionate burden due to disparities, and increasing equity of opportunity to enjoy health and well-being. The ethical principles that they considered are maximizing benefits and minimizing harm, equity, justice, fairness, and transparency. Next slide. So they have discussed what are likely CDC recommended early groups for vaccine prioritization. So not to confuse that with phases for provider enrollment, but they're also including these as phases of vaccination. So phase 1A proposed so far in discussions by CDC would be healthcare personnel. And CDC defines healthcare personnel as any paid or unpaid person working in healthcare, serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. They're including currently, again, this is a draft, in phase 1B, some rather large groups, large numbers of people, but that includes essential workers, adults 65 years of age and older, and adults less than 65 years of age with high-risk conditions for severe COVID. As I mentioned, their next meeting is next week, so we will get more details. They have, though, said that they expect that states will need to weigh in on sub-prioritization within some of these phased groups. Next slide. So just in the way of background, CDC has also provided information about the rationale for the definition that they have for healthcare personnel. It is not based on a person's title, but rather their risk of exposure. And what they have noted is the healthcare personnel who have had laboratory confirmed COVID-19 infections come from a wide range of different areas of work within a healthcare system that includes person working even management, emergency medical, social workers, counselors, food service, environmental services, housekeeping, and others. Next slide. CDC has also noted that although more of the cases of COVID-19 that are laboratory confirmed tend to be in persons who are younger. The deaths and also hospitalizations are mostly in adults 50 and older, and particularly those 65 and older. Studies that have been done by CDC and others also note that having one or more high-risk conditions also substantially increases the risk of being hospitalized with COVID-19. Next slide. The other group included in phase 1B per the CDC draft discussions on prioritization include a number of groups listed here, but that includes people in corrections, people in food processing, education, which includes daycare providers, and then a number of other different sectors, including communications, commercial facilities, defense, other emergency services such as first responders, law enforcement, child protective services, etc., energy, financial services, government, nuclear reactors, waste and material, transportation systems, and water and wastewater management systems. Next slide. Again, this is from the Centers for Disease Control from their ACIP meeting in August. And what they noted is that for phases 1A and 1B, that includes a very large proportion of the U.S. population, and it accounts for over half of U.S. adults. When you look at adults 65 and older, those with high-risk medical conditions, and essential workers, including healthcare personnel. Next slide. So those are the current draft language from CDC. The World Health Organization has also published an interim framework for COVID-19 vaccine allocation, and their overarching goals were to maximize the amount of societal good for a vaccine program. And one of their main principles that they considered was reciprocity, where there is an obligation to honor those individuals and groups within countries who bear substantial additional risk and burden of COVID-19 due to their role in the community. So they also noted that within an occupational group, there will be different degrees of risk within their jobs, and therefore obligations of reciprocity do not apply evenly to all, given that risk is greater or less for different groups. In addition, they noted that frontline healthcare and social care workers are often in close contact with people who biologically are most likely to experience serious COVID if infected, and who might be afforded some level of protection if their healthcare workers were vaccinated. So in other words, it is helpful to provide vaccine to persons so that they don't transmit vaccine to others who would be at high risk. They defined healthcare personnel as at high or very high risk, but had not provided a specific definition for high or high risk per healthcare workers. Next slide. Johns Hopkins has also published a framework for vaccine allocation. The principles that they noted were promoting the common good by promoting public health and enabling social and economic activity. The other principle was treating individuals fairly and promoting social equity, recognizing contributions of essential workers who have been overlooked in previous allocation frameworks, and then promoting legitimacy, trust, and a sense of community ownership over vaccine policy while respecting the diversity of values and beliefs in our pluralistic society. And you can find the link to their full report. Next slide. So using those principles, they came up with their goals that they proposed in their framework, and that is to prevent illness and death from COVID, and then also to prevent illness, injury, and death from other causes that are non-COVID, to protect the healthcare system, to protect essential services, to enable economic activity more broadly, to enable children and adult staff to return to school and childcare, and then among systematically disadvantaged groups and marginalized populations to reduce higher rates of severe COVID illness and mortality and address disproportionate economic and social impact. Then to prevent those at highest risk of severe illness and death, particularly those with the most years of life left to live, to reduce burdens on those with both high health and economic risks. So a lot of goals there. And again, we'll provide these slides to you afterward. Next slide, please. Again, based on their goals, then they looked at, well, what groups would fall into those various categories and goals and principles. And the groups that are specific to the healthcare sector, which we're focusing on today, would include nursing home and long-term care facility workers, home health aides, and they also include household contacts at high-risk persons, frontline healthcare workers during direct patient care, emergency medical services, healthcare support staff such as environmental, food, and maintenance services, again, emergency medicine. They looked at groups that cannot work remotely and worker groups with a high rate of lower income workers. And for healthcare, that included home health aides and long-term care facility workers, among others. And then essential workers with comorbid conditions and essential workers with high-risk household contacts. Next slide. So based on, again, all those considerations, the Johns Hopkins framework, phase 1, included those most essential to sustaining the response. So that's where healthcare personnel came in, frontline emergency medical services, and others in public health and diagnostic and immunization teams needed to address the response. They also included those most essential to maintaining core functional societies. They include frontline long-term care providers and healthcare workers providing direct patient care to patients with high-risk conditions, and then also included those at greatest risk of severe illness and death and their caregivers. Next slide. Lastly, I'm going to mention the National Academy of Medicine framework. This has also been published. Their principles included maximizing benefits, equal regard, mitigating health inequities, fairness, having recommendations be evidence-based, and transparency. Their overall arching goal was to maximize societal benefit by reducing morbidity and mortality caused by the transmission of the virus SARS-CoV-2, which causes COVID. Their allocation criteria are risk-based, and they recommended prioritizing the following groups based on risk of acquiring infection, risk of severe disease and death, risk of negative social impact if they do become sick, and risk of transmitting disease. Next slide. So what they proposed in phase 1A through the National Academy of Medicine would be phase 1A, high-risk healthcare workers, those involved in direct patient care. They specifically included in that group workers who provide transportation, environmental services, and others who would be at risk of exposure to bodily fluids or aerosols. And the rationale, again, was maintenance of the healthcare system, not exposing high-risk patients to infected healthcare workers, and reducing transmission from healthcare workers to others, including their family. Workers in communities disproportionately impacted by COVID-19 were also recommended. And then also in phase 1A, they included first responders. Next slide. In phase 1B, they recommended older adults living in congregate settings, such as nursing homes or skilled nursing facilities, and other similar settings, and people with selected high-risk, comorbid, and underlying conditions. In phase 2, they proposed kindergarten through 12th grade teachers and school staff, other workers in essential industries, older adults, adults with high-risk conditions, and then persons living in congregate or crowded settings and their staff, such as corrections, group homes, and homeless shelters. Next slide. The National Academy of Medicine Phase 3 recommendation was broader immunization of other workers, young adults, and children. And Phase 4 is persons interested in vaccination for their personal protection. Next slide. So based on these frameworks, the Idaho COVID-19 Vaccine Task Force, also that Sarah mentioned, also sought additional input from a number of different healthcare sectors in Idaho to develop and receive input on program goals for a vaccine program specific to Idaho. So those draft program goals include reducing transmission, severe illness, and death, preserving the functioning of the healthcare system, to recover functioning of society, to protect persons at risk who have access and functional needs, and to ensure equitable distribution and equity of opportunity to enjoy health and well-being. Next slide. And I will just say that, again, those are not in a prioritized order. Those goals are equal goals. In terms of the principles and factors considering for vaccine prioritization, again, the task force reviewed ethical frameworks, which I've mentioned previously, the risk of severe disease or death based on age, medical conditions, and race or ethnicity, risk of exposure to COVID-19 affected persons based on occupation, the ability to physically distance, access to personal protective equipment, and living circumstances, particularly congregate or crowded living conditions. They also considered the risk of exposing others who were increased risk of severe disease or death. So that would include those who live with or care for those at increased risk. They also consider the impact of the occupation on resuming community functioning and the maintenance of community safety, including law and order. The feasibility of implementation for specific vaccine products and the age groups for which those products end up being recommended will also need to be taken into consideration. Next slide. So we'll start first with a review of the goals of the Idaho Immunization Program, and we would be interested in your feedback. And Angela, I don't know if you could go back to the slide on goals for a minute. Perfect. Let's stop there and see if anyone has questions on whether these are the correct goals. Are there other goals that should be considered?
So this is Monica. Please go ahead and raise hands or chat, and we will address your feedback like that. We have a couple hands up.
We have Yvonne Ketchum has her hand up, please.
Thank you. Thank you for the presentation, Carolyn and Patrice. One of the considerations, I put my hand up a little earlier in the presentation, one of the considerations that we need to make is whether or not, so the vaccine is supposed to be free. So that's going to be great to get our distribution out. But the administration fees in recruiting providers and who it gets administered to becomes a question mark. Because if any of the vaccines that were highlighted previous in the presentation are issued under the emergency use authorization and not FDA approved, Medicare will not pay for the administration. And most of the payers tend to follow whatever Medicare does. And so I am concerned about the rollout of this in recruiting providers and being able to hit all these goals and some of the expense that's going to entail of having 2 vaccines and putting them in the IRIS system and covering the overhead of that with providers if this is not FDA approved and we can't get Medicare to pay for it. I know there's some work in Congress to correct that, but I just want to make the committee aware that that's an issue right now at the federal level of whether there will be coverage for the administration of this vaccine beyond the free vaccine itself.
Yvonne, thank you for that comment, and I appreciate that. It is a very important issue, and like you, we understand that that is being discussed. So definitely need to keep an eye on that.
Dr. Burgess has her hand up.
Go ahead, Dr. Burgess.
Yeah, thank you. We're going to be talking about this next, but I didn't know if you think it should go in the goals about communication and reassurance of, or maybe education to the public about the vaccines and safety and communication on how to receive them. Would that go under goals, or do you think that's just a separate issue?
I guess I think that brings up a great point that we should be much more specific about this. Program goals for vaccine prioritization. I think you bring up a critical point that communication is huge. So perhaps we should just be clearer for this, that it's prioritization is key, and maybe adding transparency. If that's what you're suggesting, that transparency issue. And then I know that Sarah's team within the immunization program is definitely working on the communications piece as well.
Dr. Bridges, I see there's a couple of comments in the chat. If Dr. Hahn or Dr. Turner would like to pull those up. Verbalize them.
I don't think they relate to what we're talking about right now, exactly the vaccine program goals. So we're following it, but I don't think there's anything right now we need to inject.
Okay, great, thank you, Dr. Hahn.
All right, at this time, do we have any more specific, we might have a minute or two for any more feedback on program goals or the principles. And
this is Daryl. I think I have my hand up, but I'm not 100% sure if anybody sees it, but Daryl Anderson, and I have two comments. First of all, Carolyn, that was a great update, and that was very helpful for a non-medical person. But my question, one question on the goals would be, and it's sort of covered under the third bullet, recover functioning of society. But I would wonder if part of this, I see the vaccine as helping enhance consumer confidence out in the state, and to have a comment that says, made some reference in our goals of enhancing the economic viability of the state. Because I do think, and I think that's sort of covered under the third bullet, but I think that as in my work on the Economic Rebound Committee, one of the key components coming out of the business community was, how do we enhance consumer confidence to get people to engage in the economy? And one of the big focal points was the vaccine, the potential development of the vaccine. And obviously there's continued work in that arena. So to me, I think if we're going to make some recommendations to the governor, I think the governor has a real focus on the economy. So some reference to enhancing that that viability, I think, of the economic viability of the state would be a good one. Secondly, and this is just a question on the vaccine in general, when we look at the rate of vaccine utilization and using the flu shot as an example, where we rank, I think, last in flu vaccine in the country, about 41% for those that are 18 years or older, and 55% for those between 6 months and 17 years. How do we take that in the context of this vaccine program and the number of people that will actually take the vaccine? Has that been considered in kind of putting these sort of prioritizations together Just curious on those. Thank you.
This is Carolyn again. Thank you so much for your comments. We did not, in thinking through specifically the prioritization of healthcare personnel, we did not consider proportion of healthcare personnel likely to be to accept vaccination if offered. That nationally, surveys suggested about 50% of adults said that they would be interested in COVID vaccination in the first 6 months to a year after vaccine is available. And one small survey suggested that was about 50 or 55% acceptance likely by healthcare personnel. So I think that highlights Dr. Burgess's point about the importance of good communication as well.
Carolyn, this is Chris. There's a comment in the chat from Rob Geddes of a proposed goal of fostering public trust of the vaccine. And Rebecca Coyle also comments, should we make a point that these are not in any prioritized order?
Yes, those are great. Thank you.
Dr. Bridges, we do have a couple of more hands raised. I see Mel Leventon and then Russ Barron after that.
And I'm just going to jump in really quickly. We still have a part of the presentation to finish. So given our time, perhaps after our 2 hands up, we'll continue to take comments in the chat box, but we may need to shift back to the presentation to move forward because we have a little bit more presentation and another discussion question for you.
Great. I too appreciate the clear presentation. I just want to make sure that everybody understands what access and functional needs means, and that people in this group are on the same page about that. My understanding, if we're using access and functional needs, then we're using that in an emergency type of situation. And so what that means is access to transportation, language access, that includes non-native English speakers. It includes literacy or lack of cognitive ability, so using plain language. And I think that touches on helping people feel confident about vaccine and such, and just making sure that materials and that access to the vaccine hits those populations. And I just wanted to really have an opportunity to emphasize that. We teach about access and functional needs here at the Silk, and many people don't know what it means. So I just want to make sure people are clear on what it means. Thanks.
Thank you so much for clarifying. I appreciate that. I'm wondering if we should go on to the next.
Perhaps we could take Russ's question or Russ's comment, and then we'll shift. I think I promised whoever had their hand up. I see one more, and then we'll shift.
Okay, thank you. I'll make this quick. I do like the goals, and I also like the suggestions that have been made. What they make me think of, though, is there been any discussion on individuals who've already had the virus and not having them like in the first phase getting the vaccine? And again, I'm not professing to be the expert on the virus, but just wondering, because there has been many who have had it, if that's been talked about.
Thank you so much, Russ. That is a great question. The vaccine manufacturers are going to be doing analyses looking at safety and effectiveness among persons who have and have not already had COVID-19 illness and infection. So we'll have, I think, more data to make a decision whether that should be a factor considered or not. Right now, it's very unclear how long antibody and protection lasts after someone has been infected.
Excellent. Thank you, everybody, for your initial comments here. And I think we did put in the agenda that this is really meant to be our initial discussion around this. So this gives us a sense for some of the questions and comments and feelings around these topics. But as we mentioned before, we will take more comment on these and make sure we share that out. So with that, Dr. Bridges, if you would like to take us to the next step in your presentation.
Yes, if you go to the next slide, and then maybe just quickly to the principles and factors considered. And I do want to make sure we get to the next section, but I would like to just let you all take one more look at this principles and factors. And we look forward to your written comments as well.
Excellent.
Perhaps we should go on a little to the next slide. And one more. Okay, thank you. So, yes, perfect, the table, thank you. So considering, you know, again, with CDC and the other frameworks that I described, healthcare personnel have been uniformly listed in that first phase for vaccination. An unknown issue is how quickly vaccine will become available and the number of doses that will be available at any given time. So it's possible that vaccine will be made available in small quantities initially, which will result in us needing to make some difficult decisions about sub-prioritization, potentially even within the healthcare sector. So as Sarah and I have both mentioned, we wanted to include some Idaho COVID-19 Vaccine Task Force and others in making some prioritization initial draft comment. And so this is the initial draft, and I will just say that we are assuming that we are going to have some additional numbers. So the estimates, the population estimates on the right-hand side are very preliminary. We will have refinements of these over time. But currently, the groups that we have so far received feedback in terms of sub-prioritization include number one, and these are in rank order, unlike the principles and the goals. So the first one is hospital and clinic staff essential for care of COVID-19 patients and for maintaining hospital capacity. The next group are long-term care facility staff, given that we know that when you vaccinate staff, for example, for influenza, you can reduce influenza outbreak in long-term care facilities. So vaccinating long-term care facility staff should also help with reducing potential outbreaks in those types of facilities. The next group within that category are home health care providers for adults 65 and older and other adults and children with high-risk medical conditions, so home health care providers. The next group are emergency medical services, and some of those who provided some preliminary input just noted that in many rural areas that there are many first responders that play multiple roles here. So that may be an expanded group, particularly in some rural areas. The third group are outpatient, inpatient medical staff not already included in the earlier groups who are unable to telework. So those who are going to have close contact with others. The fourth group include pharmacists, or fifth group, I should say, pharmacists, pharmacy technicians, pharmacy aides that are not already included in earlier groups. Obviously, many pharmacists and others work in hospital and clinic settings, and so they would be vaccinated in the earlier group, similar to other outpatient and inpatient staff. And then also included in that group 5 are dentists and dental hygienists who obviously have very close contact with patients. And then the last category is public health and emergency management response workers who are unable to telework. And we assume that was about 50% of that particular category of workers who are unable to telework. So at this point, we'd like to open up for some discussion about this draft sub-prioritization among healthcare personnel.
So again, please use hands up or chat so that we'll have a few minutes for that initial input from the group. I see a hands up from Dean Cameron, and I'm going to assume, Mel, that that was your hand up from earlier. But if not, please let us know. But I'd like to invite Dean to share his comment.
Thank you. Just a question. With the breaking of the hospital personnel into essentially two categories, I'm wondering if there's not a third category, whether it should be broke down even further, because there may be personnel in the hospital which likely do not have contact with patients, and eventually, certainly, they need to be provided access, but I don't know that I see them as a priority over public health and emergency management or pharmacists and dentists. So I'm wondering if there's certainly agree with the top category. I'm wondering if when we get to the outpatient and inpatient medical staff not already included, I'm thinking of billing personnel and others who may not qualify here. So just a thought.
Thank you for that comment.
Yeah, this is Chris. I have a couple comments in the chat I just want to bring up for broader discussion. One is for the question, does home care providers include family caregivers? So this is family caring for vulnerable adults. Start with that.
I think that's a great question and important discussion point. Right now, this only includes healthcare personnel and those family care providers for high risk. We did not include these in this discussion specifically for healthcare personnel, but that's a great question. Good comment.
Great. There's a couple more questions, and I think they're not healthcare workers in the sense that we normally think of them as far as this priority group, but I'll bring it forward. One is veterinarians, and one is volunteer LTC ombudsmen who visit LTC, is that long-term care centers or facilities? I'm used to LTCFs, and meet with residents. So I don't think they would normally be included in healthcare providers, but those two groups have been the question I was asked about them.
Thank you. So we did not include veterinarians in this particular group for healthcare personnel. My understanding is that when we talk about long-term care facility staff, that would be very broad in the similar category that CDC is defining healthcare personnel, which also includes volunteers. So those volunteers that are providing services in long-term care facilities, my understanding is that they would be included in that category. But we should clarify, so thank you for that comment.
Great. If there aren't any hands raised, I'm not looking at that right now. There are more in the chat. So Angela, please interrupt me if there are people waiting.
No, go ahead, Dr. Hahn.
Okay, thanks. A couple more. Adult protection workers, and then healthcare workers in jails and prisons. Are they captured in this table, or are they prioritized at this point?
Adult protection workers they would be included in that very last category, as I understand. If that's not clear, we'll need to make that clear. I'm sorry, and Chris, can you say the other group you were asking about?
Healthcare workers in jail and prison facilities.
Yes, definitely healthcare workers in those settings should be included, and we'll need to make that clear, so thank you.
Great. I have a few more. One is a comment on depending on the role of the pharmacist or pharmacy techs, should they potentially be higher on the priority list, and maybe separating them from dentists and dental hygienists, putting them in a different category from dentists and dental hygienists. So I don't know if other people, poor Carolyn, I know you're doing, Dr. Bridges, you're doing your best to respond, but these are hopefully discussion points as well. If people want to answer these, feel free to raise your hand and respond as well.
Chris, just one thing I'll just mention to be clear is just to reiterate that some of these groups who are, if a group or a person based on their occupation and role is included in a higher row, then they should be vaccinated with the group in that row. So you move up, not move down, if that makes sense.
Yes, Dr. Bridges and other members of the committee, we do have a hand up from Linda Swanstrom. Like to go ahead?
Hi, thank you. And yes, just responding to the question on hygienists and dentists versus pharmacists. And it's hard to look at the prioritization and know clearly who should be higher than others. And I appreciate the comment that was just made. If you're in the row, you're in the row, and you're kind of treated equally is the way I understood that. So that's good to hear. So I think it negates the pharmacist versus dentist. But one thing to keep in mind that is unique to the practice of dentistry is, as Dr. Bridges said, where you're performing the work, you're in the mouth. The work that is done generally generates aerosols, and we know that to be one of the key ways that COVID is transmitted, or the key way that COVID is transmitted. So just the nature of the work that dentists, dental hygienists, and dental assistants are performing is very high risk, and CDC does put them in one of the highest risk categories of transmission. Thanks.
Thank you. Do we have any other comments? We have a couple more minutes here. Do we have any more comments in the chat?
Yeah, Monica, I think there's a little more discussion about, I appreciate the comments about a dentist. There was a question about home care providers. Mel, who chimed in earlier, Mel chatted that home care providers should include family care workers, community support workers, and personal care attendants for people who receive home and community-based services. But then a question for long-term care facilities, does that include workers in other congregate care settings, such as the other group homes, not just SNFs? So intermediate care facilities, those types of things. So I think it does, but Dr. Bridges, I'll let you answer about that.
Yes, it definitely does. It includes the assisted living facilities, skilled nursing, and the intermediate care facilities.
Great, thank you. Any other questions that we can take a couple minutes to look at this time? Questions or comments? All right. I'm not hearing any at this time. But of course, as we have mentioned, and we will detail in just a moment, you will have the opportunity to really process some of this information and provide some more feedback in the coming week or two here. I see one more thing that popped up in the chat.
Yeah. Sorry, Monica. Yes, we're just unmuting to say that that's a great thought about vaccinators as a group. So it might be, for example, the public health district staff providing vaccines. That maybe vaccinators need to be their own group. So just a thought for discussion. If people want to respond to that, or Dr. Bridges.
I think that's a great comment. Thank you very much, Jamie.
Excellent. All right, everybody. Well, time-wise, this is a good time for us to shift to the next point in the meeting. As we anticipated in the beginning of the meeting, we wanted to give time to really hear those presentations and have some of that initial conversation. Thank you, everybody, for your comments, whether you raised your hand or you chatted. And we did anticipate that one other item on the agenda, as we mentioned earlier, where we start talking about the messages that are important to be communicating out there. We need to talk about that. We will start thinking about that between now and the next meeting, but we will defer that to the next meeting. So I just want to let you know that's where we are in the agenda. But before I forget, thank you to Sarah and Dr. Bridges for those presentations. And again, thank you for your input there. Excellent information. So now we're going to turn to our wrap up. So if Natalie, you could pull up that slide. Thank you. So an overview of our wrap up, quick meeting summary. As you all know, our main purpose today was to get clear on the purpose and goals of this advisory committee and role of the committee, and to really establish that common foundation of knowledge for the group so that we can make really well-informed decisions and have good discussion together based on that foundation of information. And I'm sure there are other links that have been sent to you and other information that you can look at as well. So that was our main purpose and our summary for today. In terms of action item, we're going to talk about action items and next steps in a moment, next meeting date and anticipated topics, and then closing. So if we could take it to the next slide, we'll talk about action items and next steps. So this will outline the opportunities for input between today and our next meeting. So number one, advisory committee members will receive a dedicated email address, so it's all going to one place, to submit further input on healthcare personnel prioritization. That would be our main point there. We did say that there might be more comments on the goals and the principles as well. So of course we will take feedback in those areas as well. Is there a comment? Okay, I'll continue. So we will make sure that you receive that email by Monday, the latest, so that you have time to provide that input. Number two, advisory committee members and the public are invited to submit written comments on healthcare personnel prioritization, as that we've been talking about, through their designated email addresses by close of business Wednesday, October 28th. And so it's a quick turnaround, but you'll have some time between now and then to determine what comments you have and to provide them. And once again, our public email address is here, COVID-19 vaccine public comments at dhw.idaho.gov. So for those listening in, if you cannot see our screen, that's what it is. COVID-19 vaccine public comment, all written out, no dash after COVID, at dhw.idaho.gov. All right, and all input, number three, all input received will be compiled by staff and sent to the advisory committee for consideration, most likely with the next advisory committee meeting package that we anticipate going out on the Monday before our next meeting. So that would be Monday, November 2nd. So those are our next steps there for gathering and then distributing that input. So if we could go to the next slide. Our next meeting, as we mentioned, in 2 weeks, November 6th from 12 to 2. Anticipated topics to share, advisory committee responses and rankings regarding healthcare personnel prioritization, and to continue our discussion of other vaccine prioritization subgroups. So that's what we're anticipating at this time. And with that, thank you everybody for your participation and comments today, and I'd like to turn it back to our committee chair and executive secretary to close out the meeting today.
So this is Patrice. I wasn't sure who's going to go first. I just want to thank you all for your participation, and also please look for your emails, and there will be work between meetings, as you already just heard. So please review the materials and give your feedback so we can make sure we have the best input, as we discussed earlier, most diverse input. We can make the best recommendations that way when we get everybody's input. And it was wonderful comments today, both in the chat and live comments. So I think we're off to a great start and really appreciate everyone's work. And I'll turn it over to Elke.
Yeah, thanks, Dr. Burgess. I just need to echo exactly what was just said. On behalf of the department, thank you very much for your participation. This means a lot for us to hear this great dialogue going on. It was great participation, and we really appreciate it. And we will be sending out materials just on the schedule Monica talked about. So please stay tuned for further information, and thank you all for joining us today.
Thank you. And with that, I believe we are adjourned. Thank you, everybody.
Yes, thank you.
Thank you, committee.